this is Dr. Kathleen Figaro coming to you from the Thyroid Channel, and today we'll be discussing hyperthyroidism and pregnancy and fertility. As always, if you have a medical problem, please discuss with a local endocrinologist. We will start with fertility in men and then work fertility in women, and then we'll talk about the complications of hyperthyroidism and pregnancy and some choices that you have as a person with hyperthyroidism who desires fertility. Hyperthyroidism overall lowers fertility in both men and women. If you're a man and you have hyperthyroidism, generally your sperm count decreases, and so your fertility decreases. However, when you're treated with a medication, usually your sperm count recovers when your thyroid levels are normal. In order to figure out how fertile you are, you would have to get a sperm count done and see how much of your sperm is mobile and normal in size and movement, and what abnormalities you might have in your sperm. So you are partially infertile, though you are not fully infertile, so you would have to watch out not to get pregnant if you were interested in avoiding fertility. But if you are interested in fertility, you'll have to find out the status of your sperm. In a woman, it's much more complicated. In a woman with hyperthyroidism, the act of hyperthyroidism does generally stop ovulation, so that makes her infertile, but it's not 100%. So while being incredibly hyperthyroid, you can ovulate once in a while and you can become pregnant. It's just much less likely. However, when you're treated and your thyroid levels get back to normal, ostensibly your ovulation should as well, so your fertility returns. The problem is that certain treatments for hyperthyroidism should not be mixed with pregnancy. And so you have choices to make related to when you have a baby after you've had this diagnosis. If you have hyperthyroidism and you've been treated with methimazole or PTU, and now you have normal thyroid level and you're off of all medications, you're ready to go and your fertility should be unchanged. If you are currently on medication, the recommendation is, if you're trying for pregnancy, that you not be on methimazole, but you instead be on PTU, propylthiouracil. And that's because while both can cause abnormalities in fetus, and methimazole can cause abnormalities that can't be remediated with surgery or other ways, and so for that reason, it is less likely to be prescribed to you if your practitioner knows that you're pursuing pregnancy, pursuing fertility, than PTU. After the first 12 weeks, because PTU is associated with excess risk of liver disease, and liver disease is more common in pregnancy, generally you'll be switched back to methimazole. So that's what happens with attempting to get pregnant and being pregnant with medications. If you decide radioactive iodine, which is the second most common treatment for hyperthyroidism, then radiation will be in your body, and you will be discussed with your radiation safety officer what the time span is based on your dose that you should wait until you pursue fertility. That span is usually between 6 months and 12 months. And the fertility, you don't need to go to a fertility expert, but the radiation safety officer, who's an expert in how long radiation can last in tissues, depending on the dose and your size and so on, can tell you whether or not you'll be at risk for excess complications. If you have surgery, the only thing that needs to happen is that your thyroid levels need to be back to normal. If your thyroid levels are back to normal, then you can pursue pregnancy with the same risks and complication rates after you've had surgery for hyperthyroidism. And then you'll pursue the recommendations for those who are hypothyroid and pregnant. So in summary, if you are hyperthyroid and you're pursuing fertility, if you're a man, you must be treated, since sperm usually are less abundant and less mobile when you have hyperthyroidism. And so in order to assure you are fertile, you might have to check your sperm count and sperm mobility. If you're a woman, depending on what kind of treatment you get, methimazole or radioactive iodine or surgery will determine the timing of your pregnancy, and all recommendations are that pregnancies be intentional and timed. And depending on what medication you might be on, there are complications of pregnancy that are associated. And so the recommendations are to be on PTU for first trimester and methimazole later in the pregnancy, because of the tendency of PTU to cause liver damage in the second and third trimester of pregnancy, and the tendency of methimazole to cause a change in fontanelle in the first trimester that can be irremediable. And then lastly, while you're pregnant with Graves' disease, your thyroid levels could normalize and you could have a temporary pause in your hyperthyroidism. However, this usually recurs after delivery, and your thyroid levels should be checked frequently during pregnancy and after pregnancy to make sure that you are safe and that you do not have any heart rhythm problems or other complications of hyperthyroidism after delivery. If you like this video, please give it a thumbs up. If you'd like to subscribe below. As always, it's a pleasure to speak with you and to talk to you about thyroid disease.